This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast, Cardiogenic Shock, Part 2. My co-host is Dr. Mustafa Ahmed, Director of the Interventional and Structural Program at the University of Alabama in Birmingham. And our special guest today is Dr. Jason Guichard, who is an advanced heart failure specialist at Prisma Health in South Carolina. Gentlemen, well, let's talk now about the ECMO. Jason, would you mind maybe defining for us what is ECMO? How does it work? The different types of ECMO that we have, and so we could really kind of see how it supports, on the circulatory system.
So ECMO is a very kind of trendy an acronym. It stands for extracorporeal membrane oxygenation. So kind of in the word is oxygenation. So generally speaking, it has an oxygenator, so it oxygenates the blood. This may be true in some configurations, but not all. So probably a better term, a better umbrella term is we call it ECLS, so extracorporeal life support. And then under ECLS or extracorporeal life support, underneath of that umbrella are two major forms of support, and that's VA ECMO or veno-arterial ECMO or veno-arterial ECLS, and then VV ECMO or veno-venous ECMO. So generally speaking, kind of broad sweeping strokes, VA ECMO or veno-arterial ECMO is used for cardiogenic shock or cardiac failure, so some sort of circulatory issue, whereas VV ECMO or veno-venous ECMO is usually due to a respiratory or breathing issue where the body is not able to oxygenate. So in VV ECMO, it's really oxygenation is kind of the big issue. And you see this a lot, in the flu season, a little bit with this whole coronavirus pandemic, although that's kind of fallen a little bit out of favor. So any sort of major respiratory issue where oxygenation is your main issue, that's where VV ECMO comes in. As being cardiologists and heart failure cardiologists, the big thing that we deal with is VA, veno-arterial ECMO, due to shock, cardiogenic shock or circulatory collapse. So that is what we'll talk about further. So VA ECMO, in a sense, is kind of complete support. So you can think of it as basically a bypass machine that's been, around in cardiovascular ORs for decades, where you have a very large hose or cannula that takes blood out of the venous side of the body, spins it, pressurizes it, and then pushes it back into the body into a return limb that goes into the arterial side of the body, which then perfuses the body. So basically taking the heart completely out of the equation, as you might imagine with open heart surgeries or where they need to stop the heart beating or arrest the heart so that they can work on it, either with fixing blockages or fixing a valve, and the machine outside of the heart basically pumps the blood. So VA ECMO is essentially kind of the same thing. It's a different circuit, it's a different unit, but the physiology and how it does it is virtually the same. So as you might imagine, these again are very large cannulas. So coming back to the size being a problem. So these are on the venous side anywhere from 23 to 25 French cannulas. So these are very large. On the arterial side anywhere from 17 to 21 French. These can be done either percutaneously in the cath lab, either through the skin, or they can be done surgically with a cut down or even with an open chest, so-called central ECMO. So these, types of things are great options for patients who are in extremis or who are very sick, because this is complete bypass. So I make the saying that you can keep dead people alive on ECMO, and that's true. They actually harvest organs, they call DCD organs this way. So this will basically perfuse a body, out, taking the heart out of the equation. to keep organs perfused, even if the heart or brain, for that matter, is not working. So if it is the more or less kind of the end all be all. It is, full support. So if you're reaching for someone, someone's really sick and you're kind of really wanting to stabilize them, this is generally, what you think about is a VA ECMO. There's several different systems. CardioHelp is a very prevalent system that's out there, or circuit. Rotaflow is another. Centromag is another. So there's lots of different pumps or circuits that are used, but at the end of the day, the cannulations and the cannulas used are basically, all kind of under the umbrella of ECLS, or extracorporeal life support.
So you have a system that really takes the venous blood, oxygenated, and brings it back in the femoral arteries. So has there been any physiological studies as to, how well the heart is perfused, or how well the brain is perfused? Because, it's like almost takes them out of the equation, yet, obviously, keeps them alive and well.
The brain perfusion is important. When you do have someone on ECMO, it's important to have arterial access, usually in the upper extremities, so we can measure directly the saturations on both sides. As you can imagine your heart is pumping forward and ECMO is shooting back up your legs. So you can reach this differential zone in the middle. The better your heart gets against your ECMO, the more that blood's coming forward. And then the watershed zone can kind of move more down towards the leg, to where the ECMO flows can get impeded. But if the oxygenated blood coming through the heart isn't adequately oxygenated, at that point you start worrying about the perfusion going to the top of the head, particularly on the right-hand side and the upper, the extremities and the head and neck at that point. So you can measure on the right-hand side, you can measure on the left-hand side, you can keep SAT monitors on, you can keep a head SAT monitors on. And so there's a lot of ways of monitoring that continuously. There have been many cases on people on ECMO for extraordinarily prolonged periods of time, weeks to months to more, who have managed to preserve neurologic function throughout that time. And so as long as attention to detail is kept meticulously, it's presumed that the blood, which is getting back up there, is oxygenated. In terms of the heart itself, ECMO does flow blood back up. And while technically the arteries can be filled, the strain and stress placed on the heart is increased. So it's afterload. Usually from a physiology standpoint, say we're talking about the device we were talking about before, like an impeller, that's taking blood out of the heart, pushing it forward, and actually decreasing the stress and strain on the walls of the heart. ECMO is pushing that blood back up towards the heart and making it harder for the heart to pump forward. So it's actually increasing load. So different strategies are used in ECMO, whether that's the left atrial cannula, whether that's some kind of other strategy, unloading strategy, or whether it's drugs to try and pump the heart forward, are used to try and ensure some kind of forward flow, but also ideally to decrease the stress and strain on that. Heart recovery is harder in that setting when the strain is increased. And so it's not ideal for a very bad heart to be on ECMO, because although it's keeping vital things alive, it's not allowing the heart to kind of recover or pump forward. And that leads to a whole host of its own complications. Jason, do you have any thoughts on that?
Yeah, like I've stressed, throughout this podcast, there are pros and cons to every device. There unfortunately is not a miracle device out there. Maybe there will be someday, maybe there won't. So every device has their pros and cons, their goods and their bads. And it's weighing that, with the individual patient and their underlying issues. And then, of course, where you think this is going. I would say probably one of the biggest things with VA, ECLS, or extracorporeal life support, you have to be careful, because like I said before, you can, keep dead people alive on ECMO, and that can get you into very sticky ethical situations. So generally, we like to, reserve the ECMO for patients that have some sort of destination. So we use VA ECMO as a bridge, either a bridge to heart transplantation or as a bridge to heart and lung transplantation, as a bridge to recovery, as a bridge to durable mechanical circulatory support, which is the LVADs, which we talked about on the last podcast. Sometimes you can put people on as a bridge to decision, but we generally like to kind of minimize that because we never want to catch ourselves flat-footed. We always want to have a direction where a patient is going to go, or have a bailout or a plan on the back end of the ECMO. So if someone doesn't have a destination, if someone is not a transplant candidate, if someone is not a durable LVAD candidate, if we do not believe that the patient is going to recover, then those would all be red flags to maybe shy away from VA ECMO and maybe choose a different temporary device, because some of these, ethical issues can be difficult for families, can be difficult for providers, and doing your best, which is not always possible. Believe me, I've had to have these very tough conversations and these very tough ethical issues, because you put someone on ECMO thinking one thing, and unfortunately it didn't turn out that way, and you're left with some difficult decisions. But the best that you can on the front end, having a game plan for the patient, if they are unable to come off ECMO, is probably one of the most important things about ECMOs, deciding to put them on, and making sure that you're making an informed decision, and that the patient and family have reasonable expectations and are aware of the decision making as well.
So this is obviously a very tough decision. It's not one man's decision or one woman's decision. Can you give us maybe an idea of what is your ECMO team composed of? And, so that obviously you have all these kind of issues that you have to discuss. Who composes your team in your facility? So
a large team, multidisciplinary, that meets off. And in each case, you really want, this is a topic of ongoing discussion at our institution, but you really do want to have as much of that team involved in the initial decision to go into ECMO as possible. Sometimes it's very hard because you have someone that's just lost a pulse immediately in front of you. And if it's in a procedure, you need to put together. And so even before procedures that are high risk now, we like to stop, think, and talk to members of that team to say, this is what the potential plans are. Do we think there's a bailout or not? Do we think there's a recovery chance? Do we think there's a plan B? And what does everyone think on this? So who does that team involve? So there's ECMO specialists that we have, usually one kind of heart failure surgeon and a critical care cardiologist, so a cardiologist that's been trained in critical care, or of course a heart failure specialist that's had training in ECMO, someone like advanced heart failure like Jason, who's had dedicated training and experience in managing that. And then you'll have interventional cardiology that often get involved, particularly from a procedural or the ECPR standpoint, to go ahead and be available and talk about strategies to go and do that. And then we'll have the pulmonary component of the ECMO team, the pulmonary specialist that's also trained. So our ECMO team at UAB actually comprises all of the above. At any one time, there's one of those critical care cardiology or pulmonary people. There's a heart failure surgeon or heart failure specialist. There's a surgical specialist. And then there's the perfusion team who will go ahead and put all that together. I'd say that's an example of a very complex and multidisciplinary approach. It can be done successfully, I'm sure, in places without all that, as long as there are very well-versed teams of specialists. And then the nursing. When you make the decision to go on ECMO, you make the decision to go and do one-to-one ECMO specialist nursing at the bedside, and people that are well-trained in dealing with that also.
Yes, we're very similar. So we've kind of broke it down into kind of three main things that the patient needs. So the patient, we have a cannulator that is part of the rounding team. So someone that manages the access site. So it was either the patient or the provider that did the cannulation, or at least knows how to manage the access site, whether or not the access site needs to be, rearranged, or if there's a bleeding complications that need to be fixed, or ischemia complications that need to be fixed. So someone that is aware of how to cannulate and alter cannulations is always part of the rounding team. The second part is kind of the patient management side of things. So someone to manage the circuit itself is always on the rounding team. And then the third out of four would be kind of the overall patient management. So if the patient's on the vent, if the patient needs antibiotics, so kind of your critical care person, pulmonary critical care would fit that bill. And then, of course, like I was talked about before, is the ECMO specialist. So this is the RN or perfusionist that is at the bedside that manages the kind of minute-to-minute, hour-to-hour aspects of the circuit. So those four people kind of form the core group of people that manage the patient as a whole. We have overlap between those. Some of our CV surgeons, they cannulate, but they also can manage the circuit. Some of them can't. Some of our pulmonary critical care people want nothing to do with the circuit and will do the critical side of things. And we'll need either a cardiologist or a heart failure cardiologist to manage the circuit. So based on people's training and comfort levels, there's a little bit of overlap and maybe even sometimes some redundancy with those four areas. But regardless, all four of those areas need to be addressed and managed each day, for each ECMO patient.
This is particularly important because the list of complications of these mechanical circulatory support devices is bigger than the list of potential benefits.
So let's talk about that. What are the complications, Mustafa?
Okay, so let's start with access. So you're going in and you're placing the device often through the leg or the arm, and you have to ensure the artery is adequately suited to have that device. Otherwise, you're going to compromise blood flow to the leg. So ischemia of the limbs, whether that's the upper limb, the lower limb, not getting enough blood supply can result in loss of a limb. And so that needs to be managed well with consideration of placement of vascular input or consideration of routine, consideration of what we call distal perfusion devices. So circuits that can go and address what's going on in the leg. But a lot of that can be just attended to by just knowing how big it is beforehand and having an adequate plan in site selection and size selection of the device. The position of the problem of bleeding. So these devices are put through large, we're making large holes in the leg and the bleeding there, and strategies to mitigate bleeding are very important. Looking at those things closely. And of course, when you move a device, then that can, to say prevent bleeding, that can result in moving where the device is itself. So that's another bleeding, another issue. The next is placement and positioning. You put something somewhere, but that can move. And even these things moving centimeters, millimeters can result in different things that can go wrong with them. When you have balloon pumps, the circuit setup, the tank that's required to kind of help the balloon pump, the EKG triggering, and all those things need to be understood and watched closely. When you're putting an impeller in, the chance for hemolysis, so the blood, as it moves through the device, to get torn up and the blood cells get damaged, releasing substances that can become toxic to the body, the kidneys, the bloodstream, and those need to be picked up carefully. The urine needs to be watched closely. Levels of blood markers need to be watched because you may need to turn the pump down or change the pump positioning, or maybe put a larger pump in, or the newer generation that can prevent the hemolysis. When it comes to ECMO and all the rest of it, perfusion to not just the lower extremities, but also the brain needs to be ensured. And that needs to be watched closely. And that's why this team of specialists that's watching this thing needs to be able to watch all this like a hawk and activate the appropriate input. And the more people you have in your team that are well-versed with not just noticing, but talking through these often several times a day, and then coming up with strategies to mitigate these. When you put someone with ECMO, the heart failure specialist may look in, or the cardiologist may look in and say, hey, but what's our bridge? What's our chance of, what's our way to ensure that the heart is being adequately cared for, even though the body is? What is our strategy to try and come off those things? Because if those aren't all paid meticulous attention to, the list of complications, which we just mentioned, can continue to grow.
No, that was a very exhaustive discussion about all the complications, all the things we need to think about really on a daily basis, if not a twice a day basis. Because one of the things that will, kind of undo all the good that you try to do for a patient is the complication. especially limb ischemia or stroke. Those are things that are difficult to take back and very difficult to come back from. So your mortality, increases substantially whenever there's a limb complication or whenever there's a stroke. So, being very mindful of, complications and being quick to address them is critically important.
And sometimes, right, Jason, these can get very complicated. For example, you've got a patient, you're on a ECMO or an impeller, you suddenly develop a condition known as, heparin-induced thrombocytopenia. Your platelets are going low, but you can't really thin the blood more. So you need to make decisions on how thin to keep blood. But then you need to use different and stronger agents to do that. And then you can have a whole host of bleeding complications or strokes that are associated. So you need to watch the neurologic function very closely. I mean, it's amazing how you get into the field and you start managing these patients. Then even after a number of years' experience, there's not a single week you're not rounding on an ECMO patient now where you're not learning something new. And that experience is important now, as new people are trained to ensure they don't make the same mistakes that a lot of us people have had made for, years.
So that's my next question. Let's say, from the point of view of the patient and the family, what does it mean to be on ECMO? I mean, can you move? There is all the positions, to kind of help the lungs. What kind of medications do I need, while I'm on ECMO? How do I look like, when I'm on ECMO? Are my kidneys functioning all right? Or am I going to need some, renal kind of therapy? What does it mean for a patient's perspective?
Yeah, that's always a great question and also very hard to answer. So what it is from a patient perspective, we can go from moving. A lot of the moving ability is going to be largely dependent on your cannula configuration, is what we call it. So whether or not you have, tubes in your legs, do you have tubes in your chest, do you have tubes in your neck? A lot of the decision and comfort level with ambulation or moving is largely dependent on where the tubes are connected. Obviously, if you have a lot of tubes in your leg, walking would be problematic. Even sitting up would be problematic. But if you have tubes kind of above the shoulders or in your neck, then sometimes getting up and walking is actively encouraged. So a lot of it depends on the cannula configuration and exactly what caused a patient to be on ECLS to begin with. As far as other things that may be added to a patient, these patients are very sick. So as you might imagine, having kidney damage requiring dialysis is always a possibility. Being on multiple drips, whether they be antibiotics or other kind of vasoactive substances to keep your blood pressure stable, are always a possibility. So generally, it can be quite intimidating being in a room in a patient with ECMO, because there's lots of machines, lots of beeping, maybe even a ventilator, depending on if there's lung compromise or respiratory compromise or not. So it can be quite overwhelming for a family and a patient. But just rest assured that all those things are needed and all there to help kind of support the patient through this very difficult process. But it can definitely be overwhelming from a patient and family perspective at the beginning.
Also, from a patient's perspective, how do you know whether I'm doing better? Mustafa mentioned a little bit about that earlier on. How do you know that, obviously you mentioned you could stay on ECMO several weeks, sometimes even months. How do you know it's time to wean off the ECMO? Or how do I know my heart is kind of getting strong enough so that I could really come off ECMO and maybe move to, either, totally removal and I'm doing well and plan to go home, or whether I need, an LVAD? Or...
Yes. So we can talk about as things get better. So we've talked about a lot of negative things, right? When someone is very sick and having a hard time and needing all these things. So now we can talk about, hopefully we're on the downhill slide. So things are now getting better. So what to expect. So as you might imagine, as things get better, things get peeled off, right? So there's less drips and less machines around. So specifically with ECMO, or really any temporary mechanical circulatory support device, there are different ways and different thinking about weaning or de-escalating temporary mechanical circulatory support. But some general rules to go by is, stable hemodynamics, off vasopressors and off inotropes mainly. No heart rhythm issues, no ventricular arrhythmias, no ventricular tachycardia, no ventricular fibrillation. And at that point, when things are hemodynamically stable, usually with the guidance of a Swan-Ganz catheter, we will begin to reduce the ECMO flow or reduce the support that whatever temporary device that you have, whether that's balloon pump or Impella or VA ECMO, begin to slowly decrease that support, slowly decrease that cardiac output that the device is providing to see how the patient's body responds and reacts. If we're able to decrease the amount of support on the device and the patient's body is able to work on its own, keep the blood pressure elevated, the heart continues to work effectively. As we continue to bring that support down, then that's excellent. That's exactly what we want to see. That means that the body is being successfully weaned or successfully de-escalated from mechanical circulatory support. So we eventually get to some of the lowest settings on the device, what we call rest settings. Usually in the ECMO world, that's a flow of about 1.2 to 1.5 liters. We generally kind of watch patients for a few to several hours, depending on the situation. And if on that lowest level of support, or what we call P2, we're setting on P2 for Impellas, and if the patient, blood pressure and hemodynamics and drip requirements stay stable and everything appears well and that the patient has improved or recovered, then at that point we would consider either decannulating, so taking out the ECMO cannulas, or removing the Impella, or removing the temporary mechanical circulatory support devices that were initially placed to support the patient. Another metric that's often used that I actually find very helpful is the cardiac power output, which we have talked about before. This is a calculated value that physicians use based on hemodynamics, your mean arterial pressure times cardiac output, which can be taken from a Swan-Ganz catheter divided by a constant 451. And as long as that cardiac power output is greater than 0.6 watts, then there's a high probability or a very good chance that the patient will be able to be successfully weaned from whatever device they have. So there are objective measures, not only subjective, but objective measures that we can use. And there are others. There are algorithms out there to wean ECMO, but those are just some kind of general guidelines that are used. And usually physicians will tell patients this. Physicians will tell families this. And as a patient or a family member, you really have to kind of look heavily to the provider to give you the necessary information to let you know how well or not well something is doing. And as providers, we need to remember that and make sure that we tell patients, as they go along, if things are improving and how things are looking, in order to, to keep them informed about their own progress.
What happens if I don't get any better? What kind of options do we have, with someone who's on ECMO?
Yes. So options from a circulatory support standpoint or from a cardiogenic standpoint, there's really only two options at this point. One would be heart transplantation, which we will be talking about here soon in another podcast. And then the second would be LVAD, or durable mechanical circulatory support, or LVAD, LVAD, which we talked about in the previous podcast. So if your body is unable to be weaned from VA ECMO or VA ECLS, those are really the only two options that you have. There's no way to go home on VA ECMO. This is a hospital-based type of support. So the only options, if you're unable to come off ECMO, is either recovery, getting better. Maybe you just need more time, for the body to heal, or heart transplantation, or LVAD. Outside of those three options, there's really no other options, and sometimes some very tough decisions and some very tough conversations need to be made at that point.
These devices are incredible technological advances. Every year we have a new iteration of something which, again, from a technological standpoint, is mind-blowing. But these are not miracle devices. These are not devices that can bring people that are already dead and suddenly regenerate organs that are dysfunctional and beyond repair. These are not devices that can suddenly, when you've started 50 meters behind the finish line because of all the damage done already, behind the start line, because of all the damage done already, that can suddenly make things normal again. And setting those expectations at the beginning of use, discussing those with the family. We just talked now about what the painful nature of some of the decisions to come off support, but really the best way to address this is a very realistic and transparent approach up front when even using these things. And just because these technologies are available does not mean we should be using them in every case we can. Putting a device in, to me, is arguably the easiest part of doing this. The thoughtful nature of the entire process, the complexities and an understanding of that's much harder to do. And that is the key, actually, to successful use of this. And as we talked about, hopefully the next 10 years sees a movement towards enhanced data collection, initiation and completion of trials, and leaves us in a position where, along with the technological advances and the training of people that can put in and run these devices, we know who to use them in, who not to use them in, and can just lead to much more successful outcomes that can help a lot more people without many of these complications.
Very well said. Thank you, Dr. Ahmed. Well, after all, these mechanical circulatory devices are there to let the heart muscle rest and heal. Dr. Ahmed, Dr. Guichard, I want to thank you very much for taking the time and discussing this device and support for our patients. Thank you.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.